Hello, hello. Yeah, it's working now. Okay, so I finished 40 questions in the morning. I'll finish another 40 right now. I think I solved this one. Got it right. Got it wrong. What defines the most likely diagnosis? I think I put HELP. But this is okay. Let's read that again. 34. You don't want parathyroid at 32 weeks gestation has been brought to the emergency department. Her husband, abdominal pain, nausea, vomiting, headaches. The patient does not complain of contractions or leakage of amniotic fluid. taking minoxidil topical. No, sorry, not topical. I mean pills, which is weird, but they say it works. What? Pathophysiology, AFLP. AFLP is unique to pregnancy. There does not appear to be a predilection for any geographical area or race. It appears to occur more commonly in primiparous women than multiparous women. Okay, beta oxidation, that's the function of peroxisome. Increased endogenous fatty acid synthesis or enhanced delivery fatty acids to the liver. Deficient incorporation or export of triglyceride as VLDL. Okay, so there's some damage that happens to the liver, like the liver's metabolism of fat, right? Some problem that affects the metabolism of fat in the liver, in the mom's liver. Toxic accumulation of intermediate metabolic products of metabolism in the maternal blood and hepatocytes. Okay. AFLP can quickly lead to multi-system organ failure, including acute liver and failure encephalopathy, gastrointestinal bleeding, pancreatitis, coagulopathy, resulting in maternal or perinatal death. Given the gravity of the disease, prompt diagnosis is imperative, followed by supportive maternal care and expeditious delivery, the only cure. Okay, I mean that will definitely affect the liver, so the coagulation, PT and PTT will be affected. EST and ALT, you won't have any problem with the RBCs, bilirubin, creatinine. Okay. Third trimester, so this woman is 32 weeks gestation, abdominal pain, nausea, vomiting, headaches, right upper quadrant tenderness, encephalopathy, so thrombocytopenia, hypoglycemia, transaminitis, elevated creatinine, prolonged coagulation, dices, and proteinuria. AFLP is associated with an increased risk of maternal and perinatal mortality that requires prompt diagnosis, maternal stabilization, expeditious delivery. Okay. AFLP. Which defines the most likely cause of this of the fetal heart rate pattern. Okay, that is That is the uterine contraction. That is the fetal heart rate deceleration. I think that's just normal, isn't it? It's kind of a little bit late. That's late deceleration. There is a mnemonic that is called veal chop. Veal chop. So variable decelerations, cord compressions. Okay, let me check that. Veal chop. Oh no, not that. OBGYN. Variable deceleration, cord compression. Early deceleration, head compression. Acceleration, okay. Late deceleration, placental insufficiency. So we're gonna ask ourselves, what is that? So this is late, kind of late deceleration. So veal chop, placental insufficiency. Okay, I was right. The correct answer is the goal of intrapartum fetal heart rate monitoring is to identify fetuses at risk of inadequate oxygenation to facilitate timely intervention. Cesarean or operative vaginal delivery to prevent hypoxic injury or death. The patient's fetal heart rate tracing shows gradual drops that begin after the onset of contraction, nadir after contractions peak, and return to baseline after contraction ends. These drops are characteristic of late deceleration. Deceleration occur when contractions cause increase in placental blood flow to such a degree fetal oxygenation. Okay, that's very interesting actually. Let me explain that. So normally what happens is that you get, let's say that this is the mother, this is the fetus. So every time a contraction happens, the fetal heart rate does something called acceleration, so it increases in fetal heart rate. The fetal heart rate increases. What happens here in uteroplacental insufficiency is that you don't have enough blood going to the fetus. So every time there is a contraction, the fetal heart rate, instead of going up, it goes down. And the explanation for that is late decelerations occur when the contractions cause decrease in placental blood flow, such a degree that fetal oxygenation is transiently interrupted. Fetal PO2 drops, and chemoreceptors initiate a reflex decrease in the heart rate. All that because of low oxygen. Okay, I mean that's a good explanation, but I'm not gonna use it. I'm just gonna memorize. Okay, so that's the mnemonic I used: variable deceleration, early deceleration, acceleration, late deceleration. So variable deceleration, cord compression. Early deceleration, head compression. Acceleration, that's okay. Late deceleration, placental insufficiency. Alright, so this patient had, let me get it. So this patient had late deceleration a little bit. Okay, everything was fine elsewhere. So, yeah. Okay. Holy shit, what's that? Is that a acanthosis nigricans or what? 20-year-old elderly Paris woman goes to the physician because she has been unable to become pregnant. The patient has a history of irregular menstrual bleeding, for which she took a combination oral contraceptive pill starting at age 14. All take the contraceptive pill, and C's were 28. Okay, that's PCOS, polycystic ovarian syndrome. Alright, urine beta HCG is negative. Elevation of what? No. I think so. FSH is high. Yeah, I think FSH is high. LH to FSH ratio is high for sure. Testosterone, I think testosterone is also high. So androgens are high in polycystic ovarian syndrome. TSH, don't think there is any change to the TSH here. I don't think the prolactin is going to be high. It's either FSH or testosterone. Let me think. Okay, let's just testosterone. Okay. The LH to FSH ratio is high, so okay. Yeah, LH to FSH ratio is high. Elevated levels of LH, testosterone, and insulin. That makes sense. So far as the most likely etiology for this patient's hematologic abnormality. that patient has 23-year-old primary development. Okay, that's a stupid question. That's a stupid question. See, the patient is dehydrated, and they're asking which is the most likely etiology for this patient hematologic abnormalities. So they got this entire question to tell you that this patient is just pregnant. Why does the patient has anemia during pregnancy? Which is plasma volume expression. That's stupid as hell, actually. During pregnancy, there's a compensatory increase in red blood cell mass. I know that. Shit. I know. So Wilgam is 28 weeks. Tdap 27 to 36. Postpartum. Hey, bro. You said hey? I don't know what aluminized means. I know what it means, but just want to know the specific meaning. Okay, that's what I thought. Okay, so I think that means if she already had a baby that is Rh positive. So let's see here. 24-year-old, 39 weeks gestation. She's blood group A negative and received anti due to vaginal bleeding. Blah blah blah. The patient received platelet concentrate for dengue fever. It's uncomplicated vaginal delivery of an infant. Which of the following is the indication of the postpartum administration of ROGAM? Okay, why is E wrong? Has 50% chance. Okay. Okay, that makes sense. Why is D wrong? All right, that makes sense. So, yeah, that's we've taken that concept in step 1, but not as in detail as right here. So D is wrong because the patient is already, alloimmunized. So the patient already is making antibodies against red blood cells. The mother made antibodies against the baby. So there is no reason to give ROGAM anymore. But here we're talking about postpartum administration of ROGAM in this patient. If the patient is blood group A positive, that means there is a high chance that the patient will be alloimmunized. So this infant with blood group A, who has like a red blood cell with an Rh positive, the mother will make antibodies against it. So we have to give ROGAM to prevent that from happening. So that's the indication. We give postpartum administration of ROGAM or ROD immune globulin in this patient for this reason. So yeah, that makes sense. I'll mark this question. I want to go back to it. Okay, which of the following is the most appropriate next step in management? All right. Okay, this is veal chop variable early. So these are early decelerations. Yeah, these are early deceleration. That means head compression. So let's see veal chop again. Identify a labor progress. Okay, which of them is the most appropriate next step in management? This is early deceleration, isn't it? 27-year-old woman, gravida 1, pair 0 at 39 weeks of gestation, comes to the emergency department because of severe contractions that started several hours ago when she experienced a large gush of fluid. Alright, that makes sense. The patient's pregnancy uncomplicated. Fetal heart rate does not change despite maternal repositioning and IV fluid bolus. Okay. I think just expect the management, don't you think? Just expect the management. I mean, she's already in labor. Yeah, the patient is showing signs of early deceleration, and the treatment is just delivery. So I don't think that's a... Oh wait, maybe because she doesn't have any amniotic fluid anymore? Rupture of membranes. Yeah, I think labor will be dangerous for him. Amnio infusion, maybe? Or cesarean. Hmm. 7 centimeter dilated, 100% effaced. Fetal head at 2 station. Okay, amnio infusion. I thought about it. Okay. Yeah, actually, this is variable deceleration. This is not early. These are different. Okay, my bad. Yeah, these are variable decelerations. Umbilical cord compression. Yeah, because he has low amniotic fluid. What about D? Oxytocin infusion. He doesn't have amniotic fluid. Yeah, the treatment is delivery, but he doesn't have amniotic fluid. He needs amniotic fluid. Variable decelerations are abrupt decreases in fetal heart rate below the baseline, whose onset, depth, and duration vary with successive uterine contraction. Variable deceleration, abrupt decrease in fetal heart rate, and whose onset, depth, and duration vary with successive uterine contractions. Okay. I don't understand here. Try changing positions to relieve pressure. That's what we have done here. The fetal heart rate does not change despite maternal repositioning and IV fluid bolus. So we tried that, it didn't work. The patient is having regular contractions. Lasted from 15. She's already in labor. We tried repositioning, we tried hydration. Now we're gonna give amnio infusion to prevent the umbilical cord compression. Okay. That's new information to me. Good answer. Let's read again. So this, the purpose of this is to monitor the patient's need of oxygen. This patient presents with variable decelerations, abrupt decrease below the baseline, whose onset, depth, and duration vary with successive uterine contractions. Variable decelerations occur when so we give amniotic fluid, amnion infusion. We hydrate the patient, and we just try maternal repositioning to relieve the pressure on the umbilical cord. Okay, I'm gonna mark this one. There's another question about about that one. What is the treatment of that one? If we have veal chop, if you have late deceleration, what is the treatment? Execute intervention. Okay, whatever. Let's just move on. Amnion infusion. So let me write it down. Veal chop. Variable deceleration. Mine. What is the M for? Maternal repositioning. Maternal repositioning, IV fluids, and amnion infusion. I'm gonna forget that, by the way. Let me write it down. Okay, I'm gonna read it in a second to just test myself. Which of the following is the most likely diagnosis? A tender swollen lymph node is also palpated in the left axillary area. On palpation, a localized fluctuant warm tender mass is felt under the left nipple. Applying pressure does not elicit any discharge. Tender and swollen lymph node. 6-week-old girl. Pain in the left breast. Wow. 6 to 8 hours. Her pain is increasing. Oh, damn. Sorry. 36-year-old mother. Okay. She has been breastfeeding every 6 to 8 hours. Her pain is being increasing. I think that's just acute mastitis. So here we have, there is a fever here. So the examination shows slight asymmetry of the breast with the left nipple pushed upwards. The left breast is edematous with erythema extending up to 3 centimeters around the nipple. Okay, that's just what is it? Mastitis. Antibioma? What is antibioma? Galactocele. inflammatory breast carcinoma, plugged ducts. I don't think galactal seal will present a swollen lymph node. Yeah. Sinusoidal pattern. See, like this prolapse. All right, I'll read it. Right, I think it's a vasoprevia, isn't it? Profuse vaginal bleeding. Yeah, so the effect. These are clue cells. So bacterial vaginosis, how do you treat it? I think clindamycin. Or doxycycline. I don't remember. Clindamycin. Okay, yeah. So that's PID, pelvic inflammatory disease. I think cervical wall motion test is what we use it. CT scan, I don't think CT would help. Urine pregnancy test. She has a fever. Pelvic ultrasound. I mean, this will, like, this is the test for chlamydia. So it could be gonorrhea. Okay. Is indicated cannot exclude or establish the diagnosis. Yeah, so cervical wall motion. Okay, so PID diagnosis clinical. That's interesting to know. All right, next step in management. The Pap test was within normal limits 5 years ago. Mammogram was normal a year ago. Colonoscopy was negative 7 years ago. So which screen test do we do? So this guy's 63-year-old. Sorry, this woman. Starting from age 45 to 75, I think, you get screening mammogram every 2 years. So if it's normal a year ago, you don't need to do another one. Colonoscopy was negative 7 years ago. Pap test was okay. You got to do a Pap test. Wait, 5 years ago. So if you're more than 65, you don't need, right? Okay, let's see. Yeah, I think it's a pap test. Yeah. Because it was normal 5 years ago, so yeah, that's good. I'm killing it, actually. Which of the following is the most appropriate next step in management of this patient? Okay, that's a new question. Let me do that again because I got one wrong before. 28-year-old Premature woman, 41 weeks gestation. Wow, that's postterm. Contraction pains. Alright, the woman is RH negative, received 10 weeks gestation, again at 28 weeks gestation. I mean, guess it's C or E. I don't remember the difference between the two. Kleihauer-Betke test and Reset test.
See?
Hmm. Yeah, sure. Yep. D. Yeah, good job. You got it right. Need to know what these tests are. Reset test and Kleihauer-Betke. Oh, okay. So you're trying to prevent the alloimmunization of the mom. Okay. You're trying to protect the next fetus, not this one. Next fetus. Okay, that makes sense. Okay, yeah, anemia causes heart failure because of high output heart failure, or hydrops fetalis. To prevent alloimmunization, unalloimmunized RHD negative women are administered anti-D immune globulin prophylactically at 28 weeks gestation. Okay, so we only give after delivery if we know for sure that this patient are Rh positive. So this is how we why we do the neonatal blood type. All right, let me read that again. 20-year-old prima gravida, 41 weeks gestation, comes to the emergency department because of contraction pains. She's admitted to the hospital due to labor and has uncomplicated vaginal delivery. The woman is Rh negative and received RhoGAM. She received RhoGAM because probably her, or for sure, like there's no other reason, her husband is Rh positive. Right? Yeah. So that's prophylaxis. If she's Rh negative, she's going to get RhoGAM as a prophylaxis due to vaginal bleeding, and again at 28 weeks gestation. Prepare next step in the management. So after he's born, what do we do? Yeah, we perform neonatal blood type. Alright, what about these tests? Kleihauer-Betke and Rosette. Okay, let me see. Probably there's a good picture or something.
In this short video, we are going to talk about the Kleihauer-Betke test. So what is Kleihauer-Betke test? It is a blood test used during pregnancy to screen the maternal blood for the presence of...
Why is the sound is 1 second?
of fetal red blood cells when Rh negative mother conceives Rh positive baby. The Kleihauer-Betke test. So what is Kleihauer-Betke test? It is a blood test used during pregnancy to screen the maternal blood for the presence of fetal red blood cells when Rh negative mother conceives Rh positive baby. What is the role of Kleihauer-Betke test? It is mainly used to assess the severity of fetal-maternal hemorrhage, a condition in which a disruption in placental barrier allows the fetal blood to enter the maternal circulation. Now, the question arises, what conditions cause fetal-maternal hemorrhage? Those include, first of all, miscarriage or threatened miscarriage of more than 12 weeks of gestation, medical or surgical termination of pregnancy at any gestation, ectopic pregnancy, heredity for more, prenatal diagnostic procedures like chorionic villus sampling or amniocentesis, abdominal trauma, external cephalic version, antepartum hemorrhage, stillbirth, traumatic delivery including the cesarean section, and manual removal of placenta. What is the pathophysiology of fetal-maternal hemorrhage? Pregnant individuals are considered Rh negative when they do not have the rhesus factor on the surface of their red blood cells. For these individuals, the introduction of Rh positive blood into their blood circulation may induce the formation of anti-Rh antibodies. This process can occur when fetal blood enters the maternal circulation, thereby inducing the formation of
Shit. Actually, my headset needs to be charged. Hello, man. Kindly write in the comment section your timings, not in the live comments because they disappear after the session. Write in the recorded. You mean like my time where I do the live? Is that what you're saying? So, okay, guys, I'll stream my entire step 2 journey on YouTube. So, if I did anything, if I studied anything like flashcards, doing questions, I'll be here. So I'll be here all day. Okay. Anytime I study, I'll just go online. Because I want people to just. A lot of people are new to the USMLE like style of studying and stuff, so they don't know how to study for the step exams. So that's just a demonstration for how to study, I guess, or how people study. But anyway, anytime I'll see if you can just activate a notification so that you can join. Kleihauer-Betke test. So that's what's that? That's like Kleihauer-Betke test. That is to assess the severity of fetal-maternal bleeding. Fetal-maternal bleeding. So if so this woman, got bleeding before, right? So due to vaginal bleeding right here. So at this time, we should have performed Kleihauer-Betke test. Okay, so let's see here. Postpartum prevention, negative. Okay, that's too much to be honest. Oh, that man currently in second year of med school here in Egypt. Thanks, bro. I'm glad that you like it. I'll be here like all the time, so join any time to study if you will. Okay, I feel like I can't focus for some reason. I don't know why. Okay, maybe I'll get some coffee and come back. One second. I can't focus. Okay. Anti-D immunoglobulin. You know what? Let's just mark this question. I don't want to think about it. Which of the following is the most appropriate next step in management? All right. Okay, what's that? Chorioamnionitis? No, wait. Yeah, I think so. No, sorry. Endometritis. That's endometritis. So what's the treatment? Dilation, curettage, estrogen, progesterone? No. Methadone, misoprostol? No. Reassurance? No. I think we gotta remove like dilation, curettage. I'm not sure. Probably B is looks like a good answer. But we also gotta give antibiotics. So, Oh wait, no. Dilation and curettage actually cause endometritis. Yeah. No. So it's A. Okay. Yeah, endometritis. Dilation and curettage is actually a risk factor. Yeah. Okay, that's an easy one. Clindamycin, gentamicin. All right. Which of the following is the best next step in management? 24-year-old woman. All right, let's read the examination here. Bimanual pelvic examination shows normal shaped non-tender uterus and no adnexal masses. Hemoglobin 11 or 12. Platelet count is 220,000. Which of the following is the best next step management? Okay, there's nothing here. 24-year-old woman, contraception counseling. Menarche at age 11. Oh, that's early. Menses typically occur and consist 6-day moderate, accompanied by severe cramping. Her medical history involves asthma, migraine. She recently became sexually active with her partner. They use condoms consistently. She mentions that they plan to get married next year and have children. All right. Okay, so there's nothing here. There's no problem here. The only problem is the severe cramping, right? And the menses occur regularly, and 6 days of moderate bleeding. It's just there's severe cramping here. She has asthma, migraine. No S3, no S4. No adnexal mass. Hemoglobin is 12. I don't understand. Where's the problem here? Okay, let's see. Combination OCPs. I mean, copper. She like trying to not get pregnant right now, or what? Okay, like they're all contraception. Okay, which is the best contraception for it, I guess. C. Ring. Okay, so I mean, the highest rate of contraception is IUDs. Maybe because she has cramping, IUDs are contraindicated. That's a weird question. I have to have like an assumption before answering this question. I don't think I have that assumption. Any ideas? I think leave-in or gastro-releasing IUDs. I think IUDs are out of the way because she has cramping. That's just a guess. Let's just try this and see where it goes. Etonogestrel ring combination OCPs. I mean, she has cramping, so preventing menses is good anyway, right? Okay, let's see. Go with this. All right, never mind. Okay, let's see if B and D were eliminated correctly. Okay, copper-containing IUDs, leave-in or gastro-releasing IUDs, are long-acting contraceptive and indicating those desiring long-term contraception. This patient wishes to start a family soon and requires a rapid return of fertility after discontinuation. Additionally, copper IUDs are associated with increased bleeding, therefore not the best alternative in anemic individuals. Okay, it has nothing to do with cramping. It has nothing to do with cramping. So she's a little bit anemic. So IUDs are not good in anemic patients. Makes sense because IUDs, the mechanism by which they work is that they induce inflammation in the endometrium, so they can cause damage to our blood vessels, I guess, leading to anemia. So anemic patients shouldn't get IUDs. And she wants to start a family next year, so she want to get back to. I don't understand why A is wrong though. OCPs and etonogestrel ring are both estrogen-containing contraceptive alternative. They're best suited for individuals who need contraception and do not have any contraindication to the use of estrogen. Okay, where the hell is the contraindication? Migraine? Okay, wait a minute. Where's the contraindication of estrogen here? Really? Like migraine is a... Oh, okay, yeah. I didn't know that, really. Wow. Okay. Let me write the contraindications for OCPs. All right. Age more than 35 or more than or equal to 35. Yeah, that makes sense because they are at risk of endometrial cancer, so you don't want to give them estrogen. Smoking, yeah, because smoking increases the coagulation, so you don't want to give the patient also OCPs. Active breast cancer makes sense, same thing. Migraine with aura, severe hypertension. Thromboembolism, Okay, that makes sense. Severe hypertension doesn't make sense though. Why? Thrombophilia, factor, okay, yeah, makes sense also. Factor 5 Leiden and antiphospholipid syndrome. Less than 3 weeks postpartum. How old are you, Hella? Hella. I mean, like, what year of med school are you? Did you graduate or are you still a student? Good job, you're doing doing better than me. Thrombophilia, factor 5 Leiden, antiphospholipid syndrome. Less than 3 weeks postpartum. POPs are recommended who cannot use estrogen-containing contraception. Notable contraindication to the use of estrogen-containing contraceptives is migraine with aura. POPs are associated with the rapid return of fertility. Okay. Oh, you're a physician. Okay, that makes sense. Right. I mean, I'm a physician too right now, but you know what I mean. Like, yeah, you're older. Do you work? What's your specialty? Don't tell me it's OB-GYN. Okay. So this is out of the way. Why is C wrong though? Okay. Combination and this ring are both estrogen. Okay, because they have estrogen in it. So family medicine, okay. All right. Progesterone only pills are recommended for women. I mean, yeah, that's a very nice review of contraception actually. A lot of things I didn't know here on how to pick an contraception for women. I didn't know. Okay. So I guess the norethindrone pill. Okay, what is that? Is that a progesterone or what? Wait. Mechanism. That's progesterone. Okay. Yeah, that makes sense. Norethindrone pill. Okay, so migraine is contraindication, active. Okay, let me redo the question again so that I make sure I got it. 24-year-old woman, contraception counseling, menarche, she has regular menses, severe cramping, medical history is asthma and migraine. So if we know that migraine is a contraindication for OCPs, so we eliminate OCPs, okay? Then she has anemia, that's why we eliminated B and D. And also because they are long-term, she wants to get children. So there are two reasons why I eliminated B and D. She wants to get pregnant like soon-ish, and she has anemia. So D and B is out of the way, A is out of the way. Now we have either C or E. Etonogastrel and ethinyl estradiol, that's still estrogen. We don't want to give that to migraine, so that's out of the way. So only norethindrone pill is the correct answer. Okay, which of the following is the most likely diagnosis? 31, primary gravid woman at 24 weeks of gestation comes to the emergency department because she experienced a large gush of fluid after sneezing. Who? She has had no vaginal bleeding or contractions. Fetal movement has been normal. Her pregnancy uncomplicated. Speculum shows a closed cervix. Small pool of clear fluid in the posterior vaginal fornix. A swab of the fluid is smeared on the slide, and microscopic examination shows arborization. Wow, what's that? So it's 31. She's pregnant. She has a gush fluid after sneezing. She has vaginal bleeding or contractions. There's no vaginal bleeding or contractions. Fetal normal. Closed cervix. Posterior vaginal fornix. Is that like the Douglas pouch? Or no, it's not Douglas pouch. Okay, one sec. Yeah, that's the like the Douglas pouch. Yeah. A swab of the fluid smeared on the slide and microscope shows arborization. Okay, vulvovaginal candidiasis. Arborization. I feel like this is candida for some reason. I mean, do they mean like candida? It's probably something I've never heard about. Probably it's leukorrhea of pregnancy. No. It's either this or that. Let me go with this. Oh, okay, so this is just a buzzword, I guess. So if you don't know what ferning is, or arborization is, I mean, how does fluid get into the posterior vaginal fornix? So, posterior. Okay, so let's say pregnancy is here. Okay. How does fluid gets here? Oh wait, is that the fornix? Oh, all right. Yeah. That's not the fornix. That is the fornix. Oh. Okay. Yeah. This is not the Douglas pouch. This is the fornix, guys. All right. That makes sense now. Here. So when she's like laying down supine position, you can see that, you know, some of the fluid came out from here and then accumulated here in the fornix. So yeah. That is easy. Swab of the fluid smeared on the slide. Okay. Yeah. I thought that's the Douglas pouch for some stupid reason. Like I started thinking about inside the peritoneum. Yeah, that's just premature rupture membrane. Okay. So there are some tests that confirm. There are some tests that confirm the pre-labor rupture membrane, which we have the nitrazane test. What is that? Nitrazane test. pH test can be done by use of nitrazane strips when turns dark blue from fluid in fluids with pH above 6.5. Okay, so that makes sense because usually the pH in the vagina is acidic, so less than 4, like 3.8 to 4.5. But if there is premature rupture of membrane, that means there is a watery fluid from the uterus that came out onto the vagina. So you're gonna see the pH is not acidic; it's like closer to neutral, right? So we test the pH with the nitrazane test. So it turns nitrazane paper blue from yellow. All right, that makes sense. Pooling test, pool of clear fluid in the vagina. All right, that's what we saw here. Small pool of clear fluid in the posterior vaginal fornix. Visualization of fluid extruding through the cervical os. Ferning test, dried fluid on a microscopic slide. Shows arborization under microscopy. Okay. Let's see the Ferning test. I want to see what is the arborization. Wow. Oh my god. Holy shit. What is that? Never heard of that before. When high levels of estrogen are present, such as just before ovulation or during pregnancy, the cervical mucus forms fern-like patterns due to crystallization of sodium chloride on mucus fibers. Wow. So this is like sodium chloride, and it's like mucus fibers from the cervix, and this crystallization of sodium chloride on top. Interesting. Okay, that's premature rupture membrane. So that's the fluid from the uterus. Ultrasound showing decreased amniotic fluid amount. Ultrasound showing decreased amniotic fluid amount. Okay, yeah, because you ruptured the membrane. So All right, final question. And now we finished 80 questions today, right? Yeah, 80. If we finish this question, I finished 80 questions a day. My goal, remember, I told you I have to finish 100 questions. So this question, I'll have just 20 questions. I have, gonna go out with my friends, to eat something and maybe hang out a little bit. And then when I go back, I'll do another stream. I'll do the 20 left. Maybe I'll do some flashcards too. Okay, so, all right, this is no man appearance. This is identity formal. Done. Easy. Okay, let's see. 62-year-old, because of abnormal vaginal bleeding, the patient first noticed blood staining in her underwear. Bleeding has progressed such that the patient has to wear perineal pads daily and is afraid to swim at her fitness club. Menopause occurred at 54. Oh, wait a minute. Blood pressure is 142. Pulse, BMI 34. Scan blood in the vaginal vault. Bimanual pelvic examination shows nothing. Complete blood count is normal. Pelvic ultrasound. Okay, that is choriocarcinoma, isn't it? Yeah, we gotta just... I mean, the woman is 62. She's not gonna get pregnant anymore. Let's just remove the uterus. And this that. Okay, should we do a biopsy first? Or should we just remove the uterus? I mean, she has the risk factors. She's old. She has the abnormal vaginal bleeding. She has blood staining, right? So it's pretty high risk. Should we do the biopsy just to feel comfortable about removing the woman's uterus? All right. I don't think this is... it's either biopsy or hysterectomy. Okay, let me think. What do we do? What do we do, guys? Endometrial biopsy or just remove the uterus directly? Okay, let's do biopsy, right? In order to have a rationale for removing the uterus. 1, 2, 3. Okay. This patient presents with postmenopausal bleeding, endometrial cancer. However, this patient nulliparity. Okay, wait. Why did I say choriocarcinoma? Oh, because of the snowman appearance. Yeah, I'm stupid. Risk factor for endometrial cancer include increasing age, obesity. Right, obesity is a risk factor. I didn't know that. Oh, that makes sense because obesity, like fat cells, releases estrogen, so estrogen will stimulate the endometrium. Yeah, nulliparity because she has high levels of unopposed estrogen, hypertension, late menopause, diabetes. Patients present with necessitates endometrial sampling through biopsy or dilation curative. She'll not use them. Yeah, I thought B2. Yeah, I thought if she's not gonna use them, so probably remove them directly. But I think we can't just yeah, we can't just do a major operation like that without... Yeah, hysterectomy with bilateral is indicated for an operable patient whose endometrial sampling shows localized endometrial cancer. Okay, thank God. All Right, we finished for 80 questions today. Let me go quickly on the mistakes I got. Yeah, so this is, I didn't know that middle schmers can be like a pain that stays for like a couple of hours to 2 days. I thought it's just a temporary pain. I was wrong. Okay. Let's see this. Okay, TDAP is given at 27 to 37 weeks gestation. That's TDAP. The ROGAM is at 28 gestation, right? 28 gestation. This woman is 14 weeks gestation, so we gotta give all the pregnant females influenza vaccine. All right, this one, I didn't remember that FTA, fluorescent treponemal antibody absorption test, is a confirmatory test. I thought it's screening. So this is a confirmatory test. Sorry, I thought VDRL is confirmatory test. It turned out E is screening. So in this woman, she's pregnant, and we did her RPR. It was positive. And then what's the next step? We got to confirm that she's really positive. So we do the FTA ABS test. Okay, that's the next step. Yeah. Number 9. The patient is stable, and there's no need for laparoscopic surgery because she's stable. Yeah, she has ectopic pregnancy. So we give the patient 1 dose of methotrexate. This one I got wrong because I thought this is ovarian cyst, but it turns out to be teratoma. And teratoma is just going to cause ovarian torsion and necrosis. Yeah, this is teratoma. This one I thought it's ectopic pregnancy, but it turned out to be what is it? Abortion. Yeah, because the cervix was dilated. Yeah, this one I fucked up. The pH is 4, so that's Canada. Yeah, that's Canada. If it's more than 4.5, it's going to be trichomoniasis, or vaginosis, right? Yeah, more than 4.5. So I fucked that up. This one, yeah, so you don't want to give estrogen plus progesterone. You just give estrogen. Yeah, next step is not biopsy here, it's MRI, breast MRI. Okay, so if you have nipple discharge, like blood, okay, you gotta consider that this is cancer. You gotta have this assumption here that it's cancer. So you gotta do everything you can. You gotta do imaging. If the imaging is negative, you gotta do a biopsy, even if the imaging was negative. Okay, so all the imaging, you gotta do a mammogram, you gotta do ultrasound, and then you gotta do MRI. So bloody unilateral nipple discharge is most commonly due to intraductal papilloma, but carcinoma must be ruled out first with ultrasound, mammography, fine needle aspiration, or core needle biopsy for suspicious mass. In a patient with normal ultrasound, the next step is to obtain breast MRI. Okay, this one, yeah, this one is stupid. This is the okay. Let me, where's the feedback here? There's feedback. Yeah, let me send them feedback about this question. This is stupid, actually. Yeah. Okay, if they respond, I'll let you guys know the response. Okay, 29. Yeah, that's I have a problem with this, but now I got it. So you give RhoGAM in order to prevent alloimmunization. Alloimmunization means the mother makes antibodies against the fetus antigens, or Rh antigens. Okay, that's amni infusion. That is early, that's variable deceleration, so veal chop. That means cord compression, so you do maternal repositioning, and you do amni infusion and IV fluids. Yeah. Okay, next question. Which of the following is the most appropriate next step in management? So, yeah. What is the indication for postpartum RhoGAM or RhoGAM? What is the indication for postpartum RhoGAM? Okay. Yeah, that's endometritis. Yeah, we got it. Okay, that's perfect. Actually, not bad. I thought I'm gonna do worse than that. It's not bad. Okay, I actually have some time for doing more questions. Let me do another 10 or something. Let me do a 40 question block and then continue it after. Okay, how many questions we have left? Okay, I have about 1900. All right, that's good. Which of the following is the most appropriate indication for the use of systemic hormone therapy, replacement therapy? Most appropriate indication for the use of systemic hormone indication. Hormone replacement therapy. Okay. Yeah, that's an easy one. Treatment of genitourinary syndrome, you just give topical estrogen. Yeah, vaginal estrogen preparations. Which of the following is the most appropriate contraception for this patient? All right, let's see. Okay, now we understand contraception, all right? I would not get this question wrong. 24-year-old woman, heavy menstrual bleeding and fatigue. Does she has anemia? All right, she has anemia, so we will not give IUDs. Okay, will not give IUDs. Menses occurs every 30 days. Wants to a more reliable method for contraception. That's actually scary because the most reliable ones. Hey, bro. Actually, I took a break like an hour and a half. I slept for a while, and then I kept on. I finished like 80 questions, and I'm on my way to finish like 120 questions, hopefully, inshallah. Okay, so 24-year-old woman comes to the physician, heavy menstrual bleeding. Okay, so I don't know if we're just gonna eliminate these two. Let me see. Last year, her mother was diagnosed with a P and was found to be heterozygous for factor V Leiden. So this is hormonal contraceptive vaginal ring. Okay, let's eliminate that. Oh, sorry. Yeah, let's eliminate that. The patient also underwent screening and okay, yeah, she is also carrier. All right. Okay, I hope that's not wrong. Thanks, bro. I hope this is not wrong. I feel like if this is wrong, I'm gonna doubt all my. Bismillah. Oh no, bro. Progesterone releasing intrauterine device. Yeah, I felt because she wants something more reliable. So she wants a more reliable method for contraception. The most reliable way, like the most reliable method of contraception is IUDs. No word about it. IUDs are the most reliable. So, okay, estrogen containing contraceptive should be avoided. Oh, all right. That's progesterone. But still an IUD, she has anemia. Estrogen containing contraceptive should be avoided in individuals at an increased risk of thromboembolism. Intrauterine copper containing devices or progesterone only contraceptives should be used in these individuals. What time is there? It's 5:35 now. 5:35 p.m. Estrogen containing contraceptives should be avoided in individuals at an increased. Okay, that makes sense. Intrauterine copper containing devices or progesterone only should be used in these individuals. In patients with anemia, in addition to a history of thrombophilia, IUD are not. Oh, okay. So only copper, guys. Only copper containing IUDs that cause bleeding. So not progesterone. Okay, actually, you know what? Let me just make sure that I'm right. Because I was almost sure that I read that IUDs. Okay, where's yeah. Let me review that quickly. Where's the question? Where's isn't oh this is the one, sorry. Yeah. Yeah. Okay, so oh, okay, see guys? In which specialty are you interested? To be honest, I'm waiting for my step 2 score. Like I have to finish step 2 first. But the specialty that I really like, and I think I'll be very happy if I got in, orthopedic surgery. I feel like this is gonna be very interesting to me. Like I'll feel so accomplished. And yeah, that's a specialty. But the problem is you gotta do a lot of research. Like scores is not enough. Like I'm talking about at least you need a 260 on step 2. So that in addition to the research, that's crazy. Okay, copper containing intrauterine device, leave-in orgastral releasing intrauterine device are long-acting contraceptives are indicated in those desiring long-term contraception. This patient wishes to start family soon. Yeah, see, copper-containing IUDs are associated with increased risk of bleeding. Okay, yeah. So my bad. I eliminated E because she has anemia. I shouldn't have done that. I should have just eliminated copper-containing IUDs. Yeah, I think I do. I do need like 100 publications. It's about at least 3 years research, at least. So yeah. Okay, so progesterone releasing. I shouldn't have removed that. Let's see why. I hope so, bro. Thanks so much. I appreciate it. Okay, a diaphragm with spermicide is a barrier. It's a non-hormonal form of contraception. It's not the most effective form, definitely. Yeah. IUDs are the most effective, for sure. This 24-year-old has heavy bleeding during her monthly menses. Her history of being heterozygous factor V Leiden carrier, in addition to having a family member with inherited thrombophilia and a prior episode of thromboembolism. But her had an increased risk of thromboembolic event, the lifetime probability of developing. Okay, instead progesterone. Alright, that makes sense. Yeah. Let's move on. Which of the following is the most likely cause of this patient presentation? Okay, let's see the examination. Pelvic examination normal. Prolactin, TSH, FSH are normal. Patients prescribed 10 milligram of medroxyprogesterone daily for 10 days, after which she does not have any vaginal bleeding. Oh, okay, I think that's a test I remember from step 1. 10 milligram medroxyprogesterone daily for 10 days, after which she does not have any vaginal bleeding. Okay. Damn, 12:40 past midnight. So like, it's 5:40. So like, 7 hours difference. Have a good day, brother. Good night. Make sure to join. Thanks for your comments. Okay, let's read 29. No menstrual period in 2 years. Wow. No menstrual period in 2 years. Menarche, age 12. Prior to pregnancy. Mens occurred every patient vaginal bleeding. 3. So before her pregnancy didn't have. Oh wait, yeah. Which was suction, curettage, and multiple transfusion. That's why. That's Asherman syndrome. So you remove the endometrium, so no more suction, curettage, and multiple transfusions. Oh, she stopped producing milk. Lactational amenorrhea, no way. It's 11 months ago. Intrauterine scarring, probably, yeah, because of the suction. Okay, wait. Why did she stop producing milk though? Thanks, brother. Bye. Intrauterine scarring doesn't account for why she's not breastfeeding. Also malaria anomaly, like, what the fuck is that? Pituitary infarction. That is a possibility, for sure. Hemorrhage, yeah, here it is, yeah. Oh no, wait. Asherman syndrome. Okay, I was right the first time. Suction, curettage, endometrial damage. Why is she not breastfeeding now? That's weird. Oh, alright. Yeah, Okay, so she breastfed. Okay, she stopped 5 months ago. So after hemorrhage, she's still even breastfed. So that's why it's not pituitary infarction. Okay. So I'm done with step 2. CK YouTube recommend this video for me. Still, I like the video for analytics. Thanks, bro. I appreciate it. What was your score in step 2? Megas Telix. Where are you from, too? Why did you stop producing milk? Low to 20s. That's fine. Did you match here in the US or you didn't even travel? Applying this here. Good luck, bro. What specialty do you want? Oh, okay. Okay, so she gets withdrawal. Thank you so much, bro. Hopefully I'm gonna get takes CK like August or something. Hopefully. I still don't understand. Like I still don't understand why is she not breastfeeding. There's nothing here. Why is she not breastfeeding? Okay, I'm actually so tired. Okay, let's just, I'm going to end the stream here, and I'm going to continue these 20 questions tonight with a new cup of coffee, guys. I'll see you later.